So what we have here, you guys, is gross anatomy of the heart. Okay, this is one of the large models. They're all a little different. The keys are all a little different. But the structures are the same. And with a little bit of time and practice with this material, you are going to be able to identify a given structure on any model, any diagram. Because at the end of the day, a heart is a heart, and the SVC and IVC always go to the right atrium. The bicuspid valve always separates the left atrium from the left ventricle, and so forth. Okay. I want to start off by pointing out the external structures on this model. Probably it's going to fall apart a little bit, but when you're orienting yourself and trying to first figure out what's what, this is sort of how the heart sets in the body, okay, as you're looking at a patient. And so the first thing really to notice is that there are some large vessels that are coming down the anterior heart front and center. And if you could see through the heart wall, you'd see that the wall that separates the two ventricles runs right through here. It's called the interventricular septum. The septum runs through here, and these blood vessels here show you from the outside, from external point of view, where that septum is. So this is roughly the division between right and left ventricle, okay? So I'm not going to do this, but if I was to point right here and say, what chamber is this, roughly or approximately, I hope you'd know that these vessels separate right from left, and that the way these vessels run here separates superior from inferior, it's atria from ventricles. So you could maybe pin down that the right ventricle is here, and the right atrium is here. The left atrium is over here, and the left ventricle is over here. This is an anterior view. These pink elephant ear, cauliflower-looking structures, there's one on the right and one on the left. These are the auricles. Auricle means ear. This does not look a lot like an ear, except the ear of a wrestler that has that cauliflower ear, which is kind of gross. But this is an extension of the atrium. It expands along with the atrium when it fills. It's called the auricle. And they look more like elephant ears than human ears. Which reminds me, there's a snack at the Illinois State Fair called elephant ears. I'm not sure if you guys have ever had one, but it's a big fried piece of dough. It looks a little bit like this. God, how good does elephant ear sound right now? If you look at the heart from the back, you can get a similar approximation where vessels running horizontally through here mark the boundary between atria and ventricles. And then again, there is a pretty large vessel, in this case coming from the right coronary artery, that swings around posteriorly and down towards the apex. It's the posterior interventricular artery. It's number 46 on this model. And it runs in something called the posterior interventricular sulcus, which is a groove. There's an artery and a vein and a bunch of fat that fills that groove, and it shows you where the interventricular septum or wall is posteriorly. So from a posterior view, again, you could use this landmark and this to approximate roughly the left and the right ventricles, okay? From this view, it's very easy to imagine and predict where the right atrium would be, because the vena cava here and here are seen entering the right atrium. The left atrium is also pretty easy to spot from the posterior view, because there are the four pulmonary veins entering it. They're red, there's four, and these are the pulmonary veins that dump oxygen-rich blood into the left atrium. These large blood vessels that occupy this area known as the base of the heart. It's opposite of the inferior point or apex of the heart. These are the blood vessels sometimes called the great vessels. They're the aorta, pulmonary artery, vena cava. These occupy the base of the heart, okay? They're often blue and red on models, but the shape and the position is most reliable because this structure is blue. But this is the trachea, the windpipe. So the position and their relationships with each other is really the best, and the shape is much more reliable, in my opinion, than color. But either way, the two large veins, the largest veins in the body, as a matter of fact, that empty into the right atrium are here, just a cuff cut off really near the atrium, is the inferior and superior vena cava. Okay, this is the SVC and the IVC, and they empty into the right atrium. Okay, you're looking from the back here. Immediately lateral to the left of, patient's left of, is the arch-shaped aorta. Okay, the three branches of the aorta are a pretty dead giveaway, and its arch shape really being sandwiched between the pulmonary artery and the superior vena cava. This is the aorta. Okay, from where it exits the heart to here is known as the ascending aorta. Remember, blood is flowing in this direction out to the head and to the rest of the body. This is the ascending aorta, and this is what we call the arch of the aorta, where it arches over the heart before it dives down into the chest and abdomen. The part that's been cut off and removed that continues down is the descending aorta. Okay? Those are the parts of the aorta. The very first branches of the aorta are not the arch branches. The very first branches of the aorta are the right and left coronary arteries. Coronary arteries supply the heart with oxygen-rich blood from itself, from the left ventricle, through the aortic valve, and immediately distal to the aortic valve is the takeoff of the right and left coronary arteries. On this model, you see the left coronary artery sneaking out from under the left auricle and the pulmonary artery, and it sneaks out, even though it's coming from this blood vessel. It dives under and it sneaks out here laterally. And it immediately gives off the large anterior intraventricular artery. Okay, this is the artery that used to be called LAD, left anterior descending. If you hear an artery called that, that's what they're talking about. But we're calling it anterior intraventricular artery. This is the anterior side of the heart. It's right down, splits down the middle, and it's the immediate large branch of the left coronary after it emerges from underneath the pulmonary artery. So it gives off the AIVA, and the left coronary swings around laterally and dives. Swings around laterally, that's the left circumflex, and then it dives down. This is not the posterior intraventricular artery. This is called the posterior ventricular artery or something. It's not on our list. It's called the posterior ventricular, I believe. It is not the posterior intraventricular. It is the terminal branch of the left coronary, but it is not the left intraventricular posterior, okay? Most humans, I don't know a percentage off the top, but most humans, posterior intraventricular artery, PIVA, comes from the right coronary. That's what I'm teaching you, that's most people. Once in a blue moon, or rarely, it comes from the left, but not on this model, not in any model I'm going to show you, not on our tests. On our tests, the left coronary artery terminates, but not over the septum. The right coronary artery, actually, if you get one of these models in your hand and you look down this little crevice, you can actually see the, I don't know if you're going to be able to see it on here, probably not. We'll peek at it when you get one, but you can actually see where the right coronary artery comes off the aorta down in that crevice, it sneaks under the auricle on the right side. It gives off some branches and swings around, and it terminates over the interventricular septum posteriorly. This is the PIVA, the posterior interventricular artery, PIVA, it's the PIVA. Okay, and that's from the right coronary. There are a number of veins that drain the heart. Okay, these coronary arteries branch into smaller and smaller and smaller arteries, just like every other artery in the body, and they form capillary networks, capillary beds in these tissues. And they join with capillaries on the venous side of the capillary bed that join larger and larger and larger veins. The large vein that drains the powerful, substantial, strong, potent left heart is known as the great cardiac vein. Okay, and the vein that drains the smaller and weaker and thinner right heart is called the small cardiac vein. And those are our veins for our purposes here. And those veins both dump and empty into this really juicy blue vein on the posterior heart. This is called a coronary sinus. And if you look into the right atrium, you're going to see an opening for the IVC, for the SVC, for the coronary sinus. Those are the three inputs. So this is going to be the final input to the right atrium that we haven't talked about yet. And if you look inside, it's going to be hard to see on here. But if you look inside, you're going to see an input from SVC, from IVC, and from coronary sinus. Okay. The coronary sinus is the segment of a vein that has all of the blood drained from the heart muscle being returned to the right atrium. It'll be carried on to the lungs for reloading of new oxygen. I think that's about it for external. Remember that the coronary sulcus is the transverse or horizontal groove that the coronary arteries run in. It is the external indicator for where the atrial and ventricle border is, the junction, the AV junction, or the AV border. It reminds me of a belt wrapped around the heart, and that's the coronary sulcus. Sulcus is a groove. If you were to cut the heart like this, you could really get the sense that there's 4 chambers in here. There are 2 superior atria and 2 inferior ventricles. There's a right atrium and a right ventricle. There's a left atrium and a left ventricle. And the blood flows from atria to ventricle. One direction, one-way flow throughout the entire body in the healthy heart. Each side, atria is separated from ventricles by a valve. The valves are in line with the coronary sulcus. They form a part of the AV border, the AV junction, the boundary between atria and ventricle. They're called AV valves. There's one on the right and one on the left. The AV valve on the right separates right atrium from right ventricle. You're seeing part of it here. If you look in 3D, you'd see that this valve has 3 cusps. It's a tricuspid valve. It's called also the right AV valve. Each cusp of the tricuspid valve is anchored to the wall of the right ventricle by these strings called chordae tendineae, the heartstrings. The chordae tendineae are attached to the cusps of the valve on one end and to papillary muscles on the other end. Papillary muscles are extensions of the ventricle wall muscle. This is cardiac muscle. They're extensions of that muscle. They're called papillary muscles. When this valve opens, it comes down. Blood from the atrium pushes the valve open as it comes down. When the ventricle squeezes and blood exits the ventricle out the pulmonary artery, blood pushes the valve closed. It pushes the valve closed so it can only go out one direction. If there was damage to these structures, the valve leaflet could be blown up into the atria, and blood could flow in the wrong direction. This prevents that. These do not pull the valves open, but they prevent valves from blowing up into the atria. Okay? Valves never go in this direction in the healthy heart. Okay? So blood comes through the AV valve, through the tricuspid valve into the right ventricle, and it exits. It exits through the pulmonary artery, which in this model is on this side. So we've opened the heart like a book, and we're looking now into the right ventricle from this side. This is the third cusp of the tricuspid valve, and that you're staring at is the semilunar valve. It looks like a Mercedes-Benz symbol. It has 3 cusps as well, but it does not have chordae tendineae. It does not have any cords securing those to the ventricular wall. Okay. The left heart, near this side, has 4 inputs. 1, 2, 3, 4. 4 pulmonary veins. Okay. These are the bigger and bigger and bigger veins that drain the lungs, and they bring oxygen-rich blood back to the left atrium. Blood fills the atrium, and when the atrium squeezes and contracts, it squirts or pumps blood through the left AV valve. Through the left AV valve, this is also called the bicuspid valve because it has 2 cusps. The left AV valve, or the bicuspid valve, opens when the atria contracts, and it's slammed shut when the ventricle contracts. And it's slammed closed, but it doesn't go reverse into the atrium, again because chordae tendineae and papillary muscles prevent the backwards movement of the valve leaflets, the cusps. When this ventricle fills with blood and then contracts, it squeezes the blood out into the aorta through the aortic semilunar valve. It also has 3 valves and no chordae tendineae, just like the pulmonic valve. And immediately distal to the valve, to the aortic valve, you've got the takeoff of the right and left coronary arteries. This ventricle squeezes blood out into the aorta and the pressure goes up. The blood pressure in the aorta and the bloodstream goes up. And then the ventricle starts to relax to fill again. And when that happens, the pressure drops and the blood wants to bump back a little bit up against this valve. It closes the valve, and it also fills those arteries. So unlike everywhere else in the body, the heart gets its blood flow as the ventricle relaxes. As it relaxes, that back bump, that backflow of blood pressure fills the coronary arteries and supplies the heart. I was telling people today, it's like when you're running and you stop suddenly, you go back a little bit. And that back bump of backwards pressure fills the coronary arteries during ventricle relaxation or diastole. Remember that when the heart squeezes, that contraction is called systole, S-Y-S-T-O-L-E. Systole is the contraction of the heart. So there is a ventricular systole. There's also an atrial systole. All those chambers can contract. Relaxation of a chamber is called diastole, D-I-A-S-T-O-L-E. Diastole is relaxation. It's when filling occurs. The atria go through a period of diastole, and the ventricles also go through a period of diastole. When the ventricles squeeze and contract and they send the blood out the pulmonary artery and out the aorta, that's when blood is sent and pumped out and supplied to the rest of the body. When they relax, there's a period where blood is not flowing. When they contract, they send a squirt of blood out. When they relax, that flow stops for a moment. That's why when you feel a pulse, the pulse that you're feeling represents and is coordinated with the ventricles contracting. When you feel the pulse, you're feeling a portion of blood being pumped past your fingers. So in that moment in time, you're feeling the effects of the ventricle squeezing. And the space in between where you're not feeling a pulse is when the ventricles are relaxing and filling back up again. If I was going to trace or explain the flow of blood through the heart, in pretty simple terms, and someone said start in the right atrium, what I would say is, Irving, the red blood cell is floating in the right atrium, and when the right atrium squeezes, he's pushed through the tricuspid valve into the right ventricle. After the right atrium squeezes, it starts to relax. That's when the ventricle starts to squeeze, contract, and when that happens, the tricuspid valve is slammed shut, so the blood can be forced out of the pulmonary artery. And the red blood cell, Irving, the red blood cell is flowing through the pulmonary artery on the way to the lungs. And he reaches a branch point at some point where the pulmonary artery splits into right and left, one to the right lung and one to the left lung. So he goes down the right pulmonary artery into the lungs, and eventually he's being pumped through smaller and smaller and smaller arterial branches until he reaches a capillary bed in the lungs. And it flows through an arterial side of the capillary into a venous side of the capillary. There, he picks up new oxygen into the backpack, the hemoglobin, and he's pumped then into bigger and bigger and bigger pulmonary veins. And those pulmonary veins ultimately dump into the left atrium. So now Irving, the red blood cell, is in the left atrium, and when the left atrium squeezes, he's pushed through the left AV valve, through the bicuspid valve into the left ventricle. And then, after contracting, the atrium relaxes and refills. And at that time, the ventricle starts to squeeze and contract, and it forces Irving, the red blood cell, and his friends out through the aortic valve into the aorta. And with every pump, he's pumped further and further and further downstream into the aortic arch, past a couple of the branches into the left subclavian artery, down the left subclavian artery, down the axillary artery, down the brachial artery. He reaches a fork in the road, and it happens that the blood flow takes him down the ulnar artery, into the palmar branches, out into the pinky, into the very tip of the pinky, where it arrives at the smallest arterial branch, a capillary, that has a venous partner, has a venous capillary in it, and he crosses that capillary bed after he flicks his oxygen to the tissues of the pinky, the skin, the fat, the tendons, the nerves. All those things get blood from Irving, and he continues on the venous side of the capillaries, and the veins become bigger and bigger and bigger and bigger until it's a ulnar vein, and a brachial vein, an axillary subclavian and brachiocephalic vein that leads to the right atrium. So that's the circuit, both pulmonary and systemic. But that's the circuit, and it goes round and round and round and round. For 120 days, that red blood cell follows that circuit until it dies and is eaten up by the spleen. So that's the heart. That's the gross anatomy of the heart that we need to know. A few other pieces that we left out and aren't shown on this model are the pericardium, the sac that the heart sits in. As you look directly at this heart, you're looking at the visceral pericardium. It's also called the epicardium, and it's plastered straight onto the heart. And there's a second layer of that same material called the parietal pericardium. There's some fluid and space between those two layers called pericardial cavity. But that is the serous portion of the pericardium. Two layers of the same material that fold around in on itself, and those two layers form a space or a cavity. It's pericardial cavity. There's pericardial fluid in that space. And then covering that is a much tougher layer, the fibrous pericardium. And I hope you got to feel how tough and durable the fibrous pericardium is. And I hope you can imagine that if fluid accumulated inside the fibrous pericardium, it would not blow up like a water balloon and accommodate the extra fluid, but rather it would stand firm, and that increased fluid and pressure would actually squish everything inside the sac, the heart, the blood vessels. And as you're thinking about that, I hope you remember that the right side of the heart is thinner and flimsier. It's more susceptible to that squishing down and squeezing. So are veins. You'll remember that in general, the veins in the inferior vena cava and superior vena cava are mostly adventitia, the outer layer. They don't have a strong, thick muscle layer that helps them stand open and stay open. Those types of things can become compressed and totally occluded and blocked if pressure builds up inside the pericardial sac. The condition is called pericardial tamponade, cardiac tamponade. Cardiac tamponade is life-threatening and it has to be corrected. That pressure has to be relieved so that the inflow to the right heart is restored. The inflow to the right heart is known as preload, and if the right heart's not getting preload, then the lungs aren't getting blood. Blood cannot be reoxygenated and returned to the left heart where it goes out to the systemic circuit. So cardiac tamponade that starts and has that effect all of a sudden is definitely life-threatening. It has a bunch of causes and a few different treatments, but you have to relieve that pressure one way or another. The left ventricle and the aorta are not the ones that are going to get squeezed and clamped down, not as easily as the right side. So I'm not going to test you on cardiac tamponade, but I just want to tell you where we're going with some of this in your training and help you understand how the anatomy of those two sides, how the anatomy of a big muscular aorta versus a thin, flimsy vena cava could respond differently to a buildup of pressure. And it's their anatomy that helps you predict the effect that some of these diseases and conditions can have.